Hi, this is Cherry, and hey, I want to take just a second to talk to you guys about very quickly during your primary assessment, those ABCs of your patient, assessing the respiratory status. That's the time when we need to make that quick decision. Do we need to get aggressive with our airway management, or can we continue on with our assessment without addressing the airway issues at that time? So this is not the same as taking vital signs. This happens very early as you first approach your patient in that primary ABCs when we need to make that very quick judgment. Do we have a life threat or do we not? So let's talk about this real quick, and hopefully this will help address some issues. 4 categories that our patient can fall in when we're looking at their respiratory status. So that's that airway and breathing. Number 1, it could be normal, in which case we're going to move on with our assessment and see what other issues we have to deal with. The second one is they could be in respiratory distress. So this is going to mean that they're working to breathe. There's a bit of an issue there, but they are still perfusing adequately. Okay, and we're going to talk about these in detail in just a second. The third one is respiratory failure. Now, this is different than respiratory arrest, which is the last category. Respiratory failure means that they are still breathing, but they are not perfusing adequately. And perfusion, remember, is that delivery of the oxygen to the cells that need it. So that is not happening, but our patient is still breathing. The last category, respiratory arrest, is when our patient is no longer breathing. That respiratory status has stopped. It's arrested. It's like cardiac arrest. The heart has stopped. In this case, the respiratory system has stopped. Now, as we move down this list, we're going to have to be more aggressive the farther down we get. Obviously, if it's respiratory arrest, we need to take care of that immediately. So let's talk about how these present and how we're going to respond to those. Okay. In our assessment of the airway and breathing, obviously we want to know, do they have a patent airway? Okay, but when we look at the breathing part, 3 things we're going to look at very specifically. One is going to play into this is their mental status. Okay, are they alert and oriented, or are they not? So this is going to play into that AVPU, that AVPU scale. So obviously, if they're only responsive to painful stimuli, their mental status is altered. Or if they're confused when you ask them questions, they have an altered mental status. Both of those would tell us that the brain is not being perfused. It is not functioning as it should. Very likely chance it's because it's hypoxic and lacking oxygen. Okay. Second thing we're going to quickly look at is skin color. Now, that actually falls down in the C, or the circulation part of our assessment. But we're going to look at that. It doesn't take long to take a quick look at that in whatever category it's in, and assess that. Our skin gives us a very good picture to how well our body is being perfused. So the mental status talks about how well our brain is being perfused, how well it's functioning. The skin color does the same for our body. So skin color and temperature. So we're looking at color, moisture, and temperature. Okay. The last thing we're going to look at is the quality of respirations. Okay. Now, quality of respirations is important. Not that we're necessarily listening to lung sounds here. We could if we need to. But what we're looking at is, are they moving enough air in and out of their lungs to provide oxygen to those red blood cells? Okay. If we're not getting oxygen even into the lungs, then there's no chance in heck that those red blood cells are going to be able to transport oxygen to the cells that need it. So obviously our perfusion is impaired, or very soon will be. Okay, so we need that adequate air movement in and out of the lungs. So we're going to take a quick listen or a quick look at that, and maybe a quick listen with your stethoscope if you need to. Okay, those are our three major ones. Now, there's two more here, right down here at the bottom. SpO2, which is your pulse oximetry, and capillary refill. Both of these have times when they're not going to be reliable. So if your patient's hands are cold, neither one of these are going to be effective. Okay? If you have dark nail polish, SpO2, your pulse oximetry is not going to work a lot of times if there's metal flakes in the polish. If your patient is very, very young, a child or an infant, pulse oximetry is hard to get. So that's not going to be a good resource for you at that point. Likewise, if your patient is middle-aged or older, capillary refill may not be reliable in those patients. Their circulation diminishes and capillary refill no longer becomes a good, reliable way to measure perfusion. Now, both of these, pulse oximetry and capillary refill, are simply verifying what we suspect in the top three. So if we're have an altered mental status, maybe our skin color is pale or cyanotic, and we're not moving much air, then without using cap refill or SpO2, I think we can identify that we have an issue with the airway. But if you're ever in question, those are good tools to verify. Okay, so let's talk about these categories. Respiratory distress. Okay, this is the first one. Your patients will have signs of difficulty breathing. Okay, they may tell you that they feel like it's hard to breathe. You may see signs that they're having difficulty breathing, and they may actually be working very hard to breathe. I mean, you could see them really working hard. Maybe a tripod position. Maybe they're using intercostal muscles or nasal flaring in our kiddos. Maybe they have those subclavian retractions in their neck where that's sucking in every time they take a breath. And there is some work of breathing there. So they are in distress. Now what we want to look at is their skin. In these patients, the skin may be pink, maybe slightly pale, maybe a normal color if they're not Caucasian. But it's not going to be drastically altered. Okay. Likewise, their mental status may be just a bit anxious because they're having to work to breathe, but they're answering all of your questions appropriately. They're very quick. Aside from being a bit anxious, they're responding appropriately. Okay. And then their respiration quality, they are moving. Even though they're having to work hard at it, they are still moving air in and out of their lungs. Okay. So when we see these things, even if your patient has horrendous lung sounds, maybe they've got a great amount of stridor or wheezing, when you see those things, you know they're working to breathe, but their perfusion is still okay. Now, if you choose to use SpO2, I had a hard time putting a number on here because some of your COPD patients don't have a high SpO2 even normally. So SpO2 should probably be in the 90s on most patients, but their capillary refill in the younger patients should be 2 seconds or less. Okay, so we're seeing work of breathing, but we're not seeing poor perfusion. Now let's look at respiratory failure. Okay, they may complain of difficulty breathing. Okay, and I put may because they may not be responsive enough to complain. Okay, their work of breathing could be increased, so they're working hard to breathe, or towards the end of respiratory failure, you're going to see that work of breathing start to decrease. When these patients simply just get too tired to keep working to breathe, they're going to quit working so hard. So we're not going to see that work of breathing. But we are going to see is that movement of air in and out of their lungs starts to drastically decrease. So these patients are going to have lots of signs of poor perfusion. So their skin is going to be pale, usually sweaty, cool, maybe cyanotic. Their mental status is going to be altered. They may be anywhere from very, very anxious to completely unresponsive, or anywhere in between. They might be lethargic, they might be combative, but they're going to not be in a non-altered mental status. Okay, they may have inadequate air movement. Okay, now they may not. They may be moving air okay. We're just not. Let me just change this here quick, because there, inadequate or adequate movement of air. So sometimes the problem doesn't lie in the movement of the air. Sometimes the problem lies in the distribution of the oxygen to our cells. So they may have good rise and fall of the chest, but we're seeing these signs of poor perfusion in the skin and the mental status. Okay. Whoops. Okay. In respiratory failure patients, they're going to have poor enough perfusion that your pulse oximetry is likely going to be unreliable. So I wouldn't really, if you see that their skin looks pale or cyanotic, and they have an altered mental status, I don't know that we need to even look at the SpO2 too heavily at this point to recognize that we need to get aggressive. These patients need at very least high flow O2 and likely advanced airways or mechanical ventilations. They may need to have their respirations assisted if they're not adequate. So if we're not getting that quality of air moving in and out of their lungs, that's when we may jump on and assist their ventilations. But these patients will at least need high flow O2. Likewise, capillary refill, it is still going to be reliable in your younger patients, but you're going to see it be delayed. So it's going to be more than 2 seconds for that when you squeeze the nail bed or the finger tip to have that pink back up. Okay, so back to respiratory distress. These patients might need, if their SpO2 is in the 90s but their skin is still pink, they might need a little low O2, maybe 6 liters, 2 to 6 liters via nasal cannula. I mean, you're going to have to base this upon your specific patient's presentation. But once we move over here to respiratory failure, these patients are not perfusing. They need a lot of O2 and they need aggressive airway management. Okay. And then lastly is respiratory arrest. If we don't fix respiratory failure, we will end up here. Okay. And this is when our patient is no longer breathing. Now, they may still have a pulse, but they won't for long, because once that heart becomes so hypoxic or lacking oxygen, it will also stop. So if we're in respiratory arrest with a pulse, if we don't fix this, we're going to be doing CPR. Okay, and we don't have a terribly long time to fix it. So what you're going to see with your skin is cyanotic and cool, most likely. You're going to have an unresponsive patient. There will be 0 respirations. They're not moving air in and out. Your SpO2 is not going to be reliable. I wouldn't even get it out. And your capillary refill is going to be extremely delayed, if there's any at all. So big thing here is going to be to check a pulse and see where we're at. Are we in respiratory arrest, or are we in cardiorespiratory arrest, meaning everything has shut down and we need to start CPR? Okay, so respiratory arrest is a whole different animal than respiratory failure. Respiratory failure happens when our patients are still breathing. We're just not moving the oxygen to the cells. Okay, so let's talk about these in relation to shock. We've talked about shock. We'll talk about it again. So normal respiratory status is there's no signs of shock. Everything is good. Respiratory distress, remember that's when our patients are working to breathe, but they're still perfusing. We could compare that to compensated shock. Our patient is in shock, but we're still compensating. Okay, we haven't seen that decrease in perfusion yet. Okay, all of the measures that our body's taking to work through that situation are enough to compensate. Whereas respiratory failure is very comparable to a patient who has slipped over to decompensated shock. They're working hard to breathe, they're doing everything they can to compensate, but it is not enough. Our perfusion is dropping, and we need to get aggressive with this. And then lastly, respiratory arrest could be compared to irreversible shock. It's there, it's irreversible. So in respiratory arrest, if we don't take aggressive measures to correct that and breathe for these patients, they will be irreversible shock. They will die, guaranteed. So hopefully that helps just a little bit, help differentiate what some of those terms are and how you would recognize them. I hope this helps. Look forward to your feedback. Thanks, guys.